Good morning, everyone. I am Dr. Satyabrata, MDDM clinical pharmacologist. Happy Mahashivratri to all of you. Stay safe and healthy. Today I am going to discuss on drug interactions. So coming to introduction, the drug interaction can be defined as alteration of pharmacological activity of a drug due to concomitant use of another drug or presence of some other substance. So, drug whose activity is altered is called the object drug, and the agent which precipitates such interaction is called the precipitant. Mostly, drug interactions are undesirable and rarely it is beneficial. Then coming to causes of drug interactions. There can be multiple causes of drug interactions like multiple drug therapy. If a patient is given multiple drugs, then there will be chance of drug interactions. And another cause can be multiple prescribers. If a patient is prescribed by multiple prescribers and taking lots of drugs, then there will be drug interactions. There can be drug interactions. Then another cause is multiple pharmacological effects of a drug. So if a patient is taking one drug that might be having lots of pharmacological effects, and one drug can have multiple effects also, and if it is taken with other drugs, then there might be chance of drug interactions. Then predisposing illness. In certain case of patients, there will be diseases that can lead to drug interactions. Poor patient compliance. Poor patient compliance. If patient is not taking drugs properly, then there is also chance of uh, drug interactions. Advanced age. In old age cases, there might be chance of drug interactions. And drug factors that are plasma binding, enzyme induction oblique inhibition, steep dose response curve, etc. These are also causes of drug interactions. Then coming to types of drug interactions. The drug interactions can be of various types like drug-drug interactions or drug-food interactions, drug environment interactions, drug herb interactions, and drug disease interactions. Then coming to mechanisms of drug-drug interaction, that is DDI. There can be a lots of mechanism like pharmaceutical interactions, pharmacokinetic interactions like absorption, distribution, metabolism, excretion. These are the mechanisms of drug-drug interactions, and pharmacodynamic interactions also, like direct pharmacodynamic interactions, indirect pharmacodynamic interactions. We will learn it in further. Then coming to pharmaceutical interactions. What is pharmaceutical interactions? Some drugs react with each other and get inactivated if their solutions are mixed before administration. For example, penicillin G or ampicillin mixed with gentamicin or another aminoglycoside antibiotic. Thiopentan sodium plus succinylcholine oblique morphine. Heparin plus penicillin oblique gentamicin oblique hydrocortisone. Norepinephrine plus sodium bicarbonate solution. So in this case, there will be pharmaceutical interactions. Then drug absorption interactions. Oral route most common. So absorption from GIT gastrointestinal tract mostly altered. So net effect is faster or slower absorption, complete or incomplete absorption. Then alteration of GI pH, that is, for example, antacids plus ketoconazole, antacids plus sulfonamide oblique aspirin. So if you give antacid, then the pH of the GI tract will be decreased and it will hamper the absorption of ketoconazole. If you give antacid along with aspirin or sulfonamide, then antacid will inhibit the pH and the absorption of aspirin sulfonamide will be decreased and the efficacy will be decreased. Then another thing is alteration in gut microflora. If you give antibiotic along with digoxin, then antibiotics will decrease the gut microflora and it will hamper the digoxin effect. And another is adsorption chelation complex formation. Activated charcoal adsorption. If you give antacids plus tetracycline oblique penicillamine oblique quinolones, then these are the examples of drug absorption interactions. Then drug induced mucosal damage, antineoplastic agents decrease digoxin absorption. Alteration in gut motility, levodopa, diazepam and aspirin when given with metoclopramide, rapid gastric emptying occurs and it increased rate of absorption. Same drug plus tricyclic antidepressants, then delayed emptying and decreased rate of absorption. Then induction or inhibition of drug transporter proteins. Example is digoxin plus rifampicin. So induction, rifampicin is a inducer, enzyme inducer. So that will hamper, that will cause drug-drug interaction when given with digoxin. Then malabsorption caused by drugs. Neomycin causes malabsorption leading to decreased absorption of digoxin. Then distribution interactions. Major mechanism is alteration of plasma protein drug binding. Also tissue drug binding, quinidine, for example, quinidine plus digoxin. This table shows the displaced drug displacer and effect. When warfarin is given with phenylbutazone chloral hydrate, then phenylbutazone chloral hydrate will displace the warfarin and there will be increased clotting time and risk of hemorrhage. Then if displaced drug here is tolbutamide, displacer is sulfonamide. So sulfonamide will displace the tolbutamide and effect is increased hypoglycemic effect. Then digoxin displaced drug, displacer is quinidine and effect is digoxin toxicity. So these are examples of distribution interactions. Then metabolism interactions. Metabolism of object drug is altered. CYP450 family is the major metabolizing enzyme in phase 1 reactions. And enzyme induction will increase the rate of metabolism and enzyme inhibition will decrease the rate of metabolism. So coming to this table shows the enzyme induction, object drug, precipitant and effect. Object drug is corticosteroids, oral contraceptives, coumarin, phenytoin. Precipitant is barbiturates. So the effect will be decreased plasma levels and decreased activity contraceptive failure. Then another example is object drug is oral contraceptives, OH, oral hypoglycemic agent. precipitant is rifampicin. So effect will be decreased plasma levels and decreased activity contraceptive failure. Then this is the table showing the example of enzyme inhibition. So object drug precipitant effect. Object drug tyramine rich food. Precipitant MAOI, that is monoamine oxidase inhibitor. Effect cheese reaction. If you give tyramine rich food with MAO inhibitor, then there will be cheese reaction. Then another example is coumarin. Is object drug. Precipitant is phenylbutazone metronidazole. If you give coumarin along with phenylbutazone or metronidazole, there will be increased anticoagulant activity of coumarin due to enzyme inhibition. And here another example is object drug alcohol. Precipitant is disulfiram metronidazole. If you give alcohol along with disulfiram and metronidazole, then there will be increased plasma acetaldehyde levels. So inducers are examples. For example, inducer examples are aprepitant, carbamazepine, efavirenz, nevirapine, barbiturates, phenytoin, rifampicin. And inhibitors examples are azoles, macrolides, protease inhibitors, cimetidine, grapefruit juice, etc. Then excretion interactions. Here excretion pattern of object drug alter. Bearing inhalational anesthetics, almost all drugs are excreted in urine or bile. So major mechanisms in excretion interactions are alteration of renal blood flow. For example, NSAIDs, non-steroidal anti-inflammatory drugs plus lithium. And another mechanism is change in urinary pH. For example, thiazides, astazolamide plus amphetamine. Then change in active tubular secretion, that is probenecid plus penicillins plus cephalosporins plus methotrexate. Another is change in enterohepatic circulation. For example, combined contraceptive pills plus antibiotics. So these are the examples of excretion interactions. You can go through the books and also some articles to learn more about this and understand this better. Then transporter protein interaction. Drugs affecting or transported by P-glycoprotein. Inhibitors are cyclosporine, clarithromycin, itraconazole, quinidine, ranolazine, valspodar, verapamil. Inducers are protease inhibitors like ritonavir, tiprenavir, rifampicin, St. John's wort, hypericum perforatum. Substrates digoxin, loperamide, dalinolone. Consider the PFOA in vivo substrate. So this is the example of drugs affecting or transported by P-glycoprotein. So you can go through the book and literatures to learn more about this, to understand more about this. Then coming to pharmacodynamic interactions. Pharmacodynamic interactions, activity of object drug altered at its site of action by the precipitant. Can be either direct, for example, salbutamol plus propranolol, BZD, benzodiazepine plus alcohol, or indirect. Indirect, for example, NSAIDs, non-steroidal anti-inflammatory drugs plus ACE, angiotensin converting enzyme inhibitors. So quantitatively, they can be antagonistic, additive, or synergistic. The pharmacodynamic interactions that frequently occur are mostly indirect action through physiological systems. So you can go through the book and literature to learn and understand more about pharmacodynamic interactions. So this is a picture showing adrenergic nerve ending and you are seeing the MAO, that is monoamine oxidase inhibitors inactivate monoamine oxidase and cause the accumulation of noradrenaline at the nerve ending. When lead by indirectly acting sympathomimetics, this results in a massive stimulation of the receptors and a grossly exaggerated pressure response. And in this another is the tricyclic antidepressant chlorpromazine, haloperidol, thiotixin, and magneitol, and pizotifen prevent the uptake of guanethidine and related drugs into the neurons, thereby blocking the antihypertensive effects. The tricyclic antidepressant block the uptake of mechanism by which noradrenaline is taken into the neuron and removed from the receptor area. As a result, the effects of administered noradrenaline are exaggerated. Alpha and beta blockers occupy the receptors and prevent the normal stimulant activity of the noradrenaline. Alpha blockers such as phentolamine will block the pressure effects of noradrenaline, and propranolol and similar non-selective beta blockers will antagonize the bronchodilator effects of beta agonist bronchodilators, for example, salbutamol. Then directly acting sympathomimetics act like noradrenaline by direct stimulation of the receptors, and mixed indirectly acting sympathomimetics stimulate the release of noradrenaline, and the mixed action sympathomimetics have both direct and indirect activity. So the mixed action sympathomimetics have both direct and indirect activity, and directly acting sympathomimetics act like noradrenaline by direct stimulation of the receptors, and indirectly acting sympathomimetics stimulate the release of noradrenaline. So these are some the picture showing the pharmacodynamic interactions. Then other mechanisms are behavioral DDI, drug-drug interaction. One drug precipitant alters behavior of patient to alter compliance to take other drug, that is object. For example, a depressed patient on antidepressants might become compliant to take other medication with improvement in symptoms. Drugs causing mucositis or taste changes might lead to patient not being compliant to take other drugs. For example, macrolides, tetracycline, antineoplastic drugs. The basis of certain interactions not explained. For example, ampicillin plus allopurinol, skin rashes. Basis of certain interactions not explained. So these are other mechanisms of drug interactions. Then drug food interactions. Food affects the extent and rate of absorption of certain drugs. For example, fatty food helps for absorption of glycopulvin. Calcium in milk chelates tetracyclines and quinolones. High protein intake interferes with levodopa transport across blood-brain barrier (BBB). Food also affects pharmacodynamic interactions like tyramine and cheese reaction. If tyramine is given with MAO inhibitor, then cheese reaction will occur. These are some examples of drug-food interactions. So food affecting metabolism, cruciferous vegetables and charcoal boiled meat are CYP1A2 inducers, and CYP1A2 substrates are clozapine, haloperidol, theophylline, etc. Grapefruit juice is inhibitor of CYP3A4. Then alcohol and drug interaction. Use of alcohol with sedatives and CNS depressants, central nervous system depressants, can cause excessive CNS, central nervous system depression. Acute use of alcohol by non-alcoholic individual may cause inhibition of hepatic enzymes. Chronic use of alcohol may increase metabolism of drugs like warfarin, phenytoin, probably by increasing the activity of hepatic enzymes. So alcohol and drug interaction is most important. Then drug environment interaction. Polycyclic hydrocarbons in tobacco smoke is potent inducer of CYP1A1/1A2 and possibly 2E1. So smoking can cause interaction with drugs like clozapine, olanzapine, theophylline, haloperidol, imipramine, etc., which are substrates of CYP1A2. Then drug-herb interaction. Traditional herbal medicines are quite common in many parts of the world, and these can affect a drug's metabolism. Licorice can cause loss of antihypertensive action of drugs. St. John's wort is the most documented of all drug-herb interactions used for depression, CYP3A4 inducer. St. John's wort is the most documented of all drug-herb interactions used for depression, CYP3A4 inducer. St. John's wort is the CYP3A4 inducer, and it causes increased metabolism and as a result inadequate therapeutic effect. So drug interaction cause increased metabolism and as a result inadequate therapeutic effect. You can go through different articles and books to learn more about drug herb interaction. So this is the diagram showing cyclosporine concentration of nanograms per ml, and cyclosporine 100 milligram BID, cyclosporine St. John's wort. When St. John's wort is given, begin of St. John's wort here is given, and another is end of St. John's wort. Then you are seeing the, say, if you give St. John's wort with cyclosporine, St. John's wort is a enzyme inducer, CYP3A4 inducer. So when it induces the CYP3A4, then there will be more metabolism of cyclosporine, and as cyclosporine is a substrate of CYP3A4, and CYP3A4 inducer lead to decreased effect of cyclosporine, the decreased concentration in, this is the diagram showing the concentration of cyclosporine is decreased after giving St. John's wort, and there will be rejection of graft rejection in case of and cyclosporine rejection also, and the dose of cyclosporine will be reduced, and it will not work, the efficacy will be reduced, and there will be rejection. That is, if you use cyclosporine graft rejection, then it will be not effective if it will given with St. John's wort. So in this case, you have to increase the here 175 milligram rejection and 100 milligram BID, then increase. So you can go through different articles and books to learn more about this picture and more about this drug interaction. So reducing drug interaction risk. Knowledge pharmacological effects of drug along with patient physiology together avoid potential DDI, drug-drug interaction. So you have to be knowledgeous about pharmacological effects of drug along with patient physiology, so that the drug-drug interactions you can manage will avoid the potential drug-drug interaction. So then coming to identify the patient risk factor, you have to identify the patient risk factor, thorough patient history you have to take, even of all traditional drugs and herbs. You have to know about the traditional drugs and herbs also while management, while reduce the drug-drug interaction, and avoiding complex drug regimen. You should not give complex drug regimen to a patient, so to prevent the drug interaction. Then monitoring patients for drug toxicity or loss of efficacy regularly. So you should monitor the patient for drug toxicity or loss of efficacy regularly. Consider therapeutic alternatives. If there is found therapeutic drug toxicity or anything else drug interaction, then consider therapeutic alternatives. You can change the drug or alternative methods, alternate drugs can be used to reduce the drug interaction, and educate the patient regarding the potential interaction. So the patient should be educated and should know about the drug interaction, so that the education of patient is most important to reduce drug interaction. Then information, you can find out informations about drug interaction. Stock list drug interaction provides detailed information about all reported and many under investigation drug interactions. And there are some softwares you can use to check the drug interaction like Lexi Interact, Micromedics drug interactions, IFAX, and Medscape and Hippocrates. So you can go through these softwares also. You can find out in the Google, and you can search on Medscape. The drug interaction checkers is there. You can find out the drug interactions by adding the drugs that are taken by the patient, and according to that you can change your drugs by showing to a physician or clinician. So these are the references. You can go through this Goodman Gilman, the pharmacology basis of therapeutic book, and stock list drug interactions and essentials of medical pharmacology. KD Tripathi and other articles, books. You can go through different articles, books, guidelines to learn more about the drug interactions. And at last, I want to tell you that you will know a lots of things about drug interactions by learning more and more books and literatures, and you can use it also in better patient management, and also you can discuss with other people while using this type of while you are finding this type of drug interactions, so that you can reduce the drug interaction burden on the society. So that's all for today. Thank you very much. Please like and subscribe my channel, and share my videos to every person, so that they can able to know more and more about these topics, and about the drug interactions and other topics that are given in my channel. So there will be more and more um, this type of education materials I will be able to provide to all of you. So thank you very much. Keep watching. Jai Jagannath. Happy Mahashivratri again, and happy Jagara.